Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Welcome to the deep dive. For the last, several years now, we've been watching this absolute revolution unfold in medicine.
A genuine one, yeah. It's centered around how we treat two of the biggest chronic diseases out there, obesity and type 2 diabetes.
And this whole revolution has really been powered by a class of injectable drugs, these synthetic hormones that give us this incredible new level of control over our appetite and blood sugar.
It's been transformative. I mean, these drugs, which are all built around a gut hormone called glucagon-like peptide 1, they've shown us just how high we can set the bar.
We're talking about results for weight loss and metabolic control that you really only used to see with bariatric surgery.
Exactly. But, and this is a big but, there's always been this one massive barrier.
The needle.
The needle. If you want those life-changing results, you have to inject yourself, usually once a week. And that injectable hurdle, as we call it, creates all kinds of friction.
You've got patient reluctance, for one. Then there are the logistical headaches of distribution, the cold storage, and probably the biggest hurdle of all, the cost.
And that hurdle is precisely what defines our mission for this deep dive. We're looking at the breakthrough that's trying to just completely remove that barrier.
So the central question is this. What if you could get those same powerful, transformative results, or results that are close enough to make a huge difference, with just a simple pill you take once a day?
That's the promise. Today, we are diving deep into a drug called Orforglipron.
It's a new small molecule compound from Eli Lilly, and it is, by all accounts, shaping up to be the biggest challenger yet to the dominance of those injectable GLP-1 drugs.
To do this, we've been digging through a whole stack of material. We've got a great health news analysis, but we're also going straight to the source.
We have the full Phase 3 clinical trial papers. They're called ATTAIN-1 and ATTAIN-2.
And these trials really put Orforglipron through its paces over 72 weeks. They tested its effectiveness and safety in two really critical groups of people.
First, people who already have type 2 diabetes, and second, people with obesity but without diabetes.
So our goal today is to really unpack all of this complex clinical data. We want to figure out if this pill actually delivers on its promise.
And maybe more importantly, what it means if we can finally get this level of efficacy with a pill. What does that do for accessibility, for global health, and for really the entire landscape of how we treat chronic disease?
Okay, so before we can even touch the trial results, we have to understand the how, the science behind it.
Right. The sources keep calling this a GLP-1 receptor agonist. Let's break that down. What is this hormone that our bodies already make, and why is it so powerful when we create a drug to mimic it?
So glucagon-like peptide 1, which everyone just calls GLP-1, is a hormone. It's released by special cells deep in your gut.
And this happens when you eat, right? It's like a signal to the rest of your body.
It's the ultimate signal. Think of it as your body's own very sophisticated full-tank light and metabolic regulator all rolled into one, and it kicks in almost the moment you start eating.
So when this hormone hits its receptors, what happens?
It sets off three really powerful interconnected pathways, all designed to help your body manage the food and energy that's coming in.
Okay, so pathway number one.
Yeah.
This is the one we hear about most with weight management, isn't it? The one that involves the brain.
That's the one. When GLP-1 receptors in your brain get activated, especially in an area called the hypothalamus, they just slam the brakes on appetite.
It's not just about not feeling hungry. It's also about feeling full faster.
Right, exactly. Satiety goes way up. You feel satisfied much earlier in a meal, and that feeling lasts for a much longer time. For people who struggle with obesity, this is what they describe as turning down the food noise.
That constant nagging thinking about food.
It just quiets down. So that's the input side of the equation.
What about the processing side, the part that's so critical for diabetes?
That brings us to the next two pathways. The second function is all about the pancreas. GLP-1 tells the beta cells in your pancreas to release insulin.
And insulin is what pulls sugar out of the blood.
It pulls the glucose out of your bloodstream so your cells can use it. But, and this is really important, it does it in what's called a glucose-dependent way.
Meaning it only really works when your blood sugar is high.
Precisely, which dramatically lowers the risk of your blood sugar crashing, which can be really dangerous. At the same time, it tells the body to stop releasing glucagon.
And glucagon is the hormone that does the opposite. It tells the liver to release stored sugar.
So you've got this beautiful dual action system. It boosts the hormone that lowers sugar and suppresses the one that raises it. Incredibly efficient.
Okay, and the third pathway?
The third one happens right there in the digestive tract. GLP-1 activation slows down how fast your stomach empties.
So the food just sits there a bit longer?
A bit longer, yes. Which means the glucose from that food gets absorbed much more slowly. And that prevents those really sharp, damaging blood sugar spikes you see after a meal.
So you take all three of those things together, less appetite, better sugar control, and slower digestion, and you can see why this mechanism is such a game changer.
It is. But this is also where the problem started. The reason for that injectable hurdle we talked about.
Right, because all the existing blockbuster drugs, they're based on peptides.
Yes, the vast majority of these hormones, both the natural ones and the drugs that mimic them, like semaglutide, are these large biological molecules called peptides.
And what's the issue with trying to put a peptide into a pill?
Well, peptides are just long chains of amino acids. They're basically tiny proteins.
And your stomach is designed to do one thing really, really well.
Break down proteins. Exactly. If you swallow a peptide, your stomach acid and your digestive enzymes, they just see it as lunch.
They shred it.
They completely break it down into useless fragments long before it could ever be absorbed into your bloodstream to do its job.
So injection wasn't a choice. It was a biological necessity. It was the only way to bypass the gut.
For decades, it was the only way. And that created all those barriers, the needles, the training, the complex cold chain storage and distribution. It's just a much harder, more expensive way to deliver a medicine.
And this is where Orforglipron comes in as a massive scientific leap. This is our first real rehook for you, the listener. How did the scientists at Lilly finally crack this problem?
They changed the very nature of the drug. Orforglipron is fundamentally different because it is not a peptide.
It's what they call a small molecule drug.
Right. Chemically, it's much, much smaller and way more robust. The best analogy is the difference between a delicate chain of pearls, that's the peptide, and a really durable, tightly wound knot of string, that's the small molecule.
So they basically engineered a compound that's tough enough to survive the acid bath of the stomach.
And still small enough to pass through the intestinal wall into the bloodstream.
But it still hits the same target. It still activates that same GLP-1 receptor.
Precisely. It triggers all those same beneficial metabolic pathways, but because of its chemical toughness, you can just take it as a normal pill.
And that changes everything. The simplicity, the compliance, and the cost.
The potential long-term cost, yes. Synthesizing small molecules is typically much more efficient than manufacturing complex biological peptides. This structural difference is the whole reason the medical world is looking at Orforglipron as a potential earthquake.
Okay, so with that science established, let's get to the proof, the clinical data. We'll start with the ATTAIN-2 trial.
Right. This is the one that looked at the drug's effectiveness specifically in people who already have type 2 diabetes. This is a tough group to treat.
Why is that?
Well, often in this population, weight loss and metabolic control are just more resistant. The body's systems are already under a lot of strain.
So this was a big, rigorous study.
Oh, yeah. Phase 3. It was a 72-week, double-blind, placebo-controlled trial. That's the gold standard. And it was global, running across 136 sites.
Tell us about the people in this study. What was their starting point?
They enrolled just over 1,600 people, 1,613 to be exact. Their average age was about 57, and they all had a body mass index of 27 or higher.
Then their weight.
The mean weight was 101.4 kilograms, which is around 223 pounds?
About 223, yeah. And critically, their blood sugar.
Their long-term blood sugar marker, the glycated hemoglobin, was at 8.05%.
Which is well above the target for good control.
Way above. These were people who clearly needed a better intervention.
So what do they have to do? Just take a pill every day?
Take the pill, yes. But everyone in the study, including the placebo group, was also given lifestyle modification advice. That included a pretty strict 500-calorie cut from their estimated daily diet.
And they were split into groups, right? Different doses.
Right. You had the placebo group and then 3 active groups getting daily doses of 6 milligrams, 12 milligrams, or the highest dose, 36 milligrams.
Okay, let's get to the main event, the weight loss. After 72 weeks, for that diabetic group on the highest dose, what did they find?
The results were genuinely powerful, especially for this population. The 36 milligram group saw a mean reduction in body weight of 9.6%.
Almost 10%. So for that average person starting at 223 pounds.
You're looking at an average loss of just over 21 pounds, and you have to compare that to the placebo group.
who were also on that 500-calorie deficit diet.
Exactly. They lost 2.5%. So the benefit you can attribute directly to the drug is huge and clearly statistically superior.
Now, that 9.6% figure, how does that stack up against the injectables we all know about?
Well, the experts who reviewed this data, they called it comparable to the lower end of what you see with injectable semaglutide.
Which usually gets you between, what, 10% and 15%?
Depending on the dose and the specific trial, yes. So to get near double-digit weight loss with a pill in a diabetic population, I mean, that's just groundbreaking.
And there's another detail in here that I think is really important for you to hear. It's about the super responders.
This is where the drug's potency really stands out. The data shows that 26% of the people on that highest dose,
So more than 1 in 4.
more than 1 in 4 of them lost 15% or more of their body weight.
That's a huge number. That's a level of weight loss you usually only associate with high-dose injectables or even surgery.
And they got there with a daily pill. It's a massive indicator of how effective this can be for a significant slice of the population.
Okay, so beyond the scale, the core goal of ATTAIN-2 was managing the diabetes itself.
Mm-hmm.
How did it do on blood sugar control?
The improvements were, they were dose dependent, so more was better, and they were highly significant compared to placebo. All 3 doses led to really meaningful drops in that glycated hemoglobin marker. The drug was doing its job.
Was there any data specifically on people with pre-diabetes, the ones who are on the verge?
There was, and honestly, this might be one of the most compelling parts of the whole trial.
What did it show?
Among the participants who started the study with prediabetes, a huge number of them, we're talking between 74 and 84% across the Orforglipron groups, achieved normal blood sugar levels by the end of the 72 weeks.
They reverted to normal glycemia.
Yes. Compare that to the placebo group, where only about 45% managed to do that. This shows the drug isn't just managing existing diabetes, it seems to be capable of powerful disease modification.
And I'm assuming we saw the usual cascade of other benefits: cholesterol, blood pressure, inflammation.
Just like we see with the other GLP-1 therapies, yes. The benefits go way beyond just weight and sugar. They saw significant improvements in heart health markers, lower inflammation, and drops in blood pressure.
It really underscores why getting to that 10% weight loss target is so important. It affects everything.
The entire cardiometabolic profile of the patient gets better.
Okay, let's switch gears to the other big trial, ATTAIN-1.
Right. This is where we see the drug's potential purely as a tool for weight management without the extra complication of managing high blood sugar.
This is the pure appetite suppression test in a way. Tell us about the scale of this study.
This one was even bigger. They enrolled 3,127 adults across 9 countries.
And the key difference here was the participants.
They were selected specifically because they had obesity. An average BMI of 37, average weight around 103 kilos, but, and this is crucial, they did not have a diabetes diagnosis.
So, same rigorous 72-week design, same doses, same lifestyle advice, but just a metabolically healthier starting point. Did that make a difference in the results?
It did. The results were even more impressive. In the highest 36 milligram dose group, the mean weight loss at week 72 was 11.2%.
11.2%. With a pill. I mean, that puts it squarely in the competitive range for any chronic weight management drug.
Absolutely. The placebo group, again, following the diet and exercise, they lost 2.1%. So the benefit coming just from the drug itself was a full 9.1 percentage points. It's a profound result.
Let's focus on those thresholds again, because this is what doctors and insurance companies really look at. What percentage of people got to that magic 10% weight loss mark?
This is the key metric. Over half, 54.6% of patients on that highest dose lost 10% or more of their body weight.
So more than 1 in 2 people on the drug achieved the level of weight loss that we know from other studies leads to massive health benefits.
That is an incredibly high response rate for a daily oral medication.
What about the even higher targets? Did anyone get to, say, a 20% loss?
They did. An impressive 18.4% of patients in that high-dose group lost 20% or more.
Almost 1 in 5.
Almost 1 in 5 hit a target that, again, used to be considered surgical-level weight loss. It just shows that the drug's power isn't just about the average. It includes this really strong group of super responders.
Now let's talk about what they lost. Because when you lose that much weight, there's always a concern about losing muscle or lean mass.
Mm-hmm.
Did they look at body composition?
They did, and this is so important. They used DXA scanning on a subgroup of patients, which gives you a very precise breakdown of fat versus lean mass.
And the findings?
They were very reassuring. Of that 11.2% average weight loss, they found that about 73% of it was fat mass.
So about 27% was lean mass. Is that a good ratio?
It's a very favorable and clinically acceptable ratio in the context of such a large overall weight reduction. It's consistent with what we see from the best injectable drugs.
And what about visceral fat? That dangerous fat around the organs.
That's the one you really want to see go down, and it did. The average loss in visceral fat mass was 19.0%.
Almost a fifth of it gone.
That's a highly significant number. Visceral fat is so closely linked to metabolic syndrome and heart disease risk. Reducing it by that much really reinforces the drug's long-term health potential.
So let's just pull back for a second and look at all the other good things that happen when you hit that 10% loss threshold.
The ATTAIN-1 data just showed this systemic improvement across the board. For instance, waist circumference, a really simple but vital measurement, dropped by an average of 10 centimeters in the high-dose group.
And blood pressure, cholesterol.
Significant drops in systolic blood pressure. And the lipid panel looked much better, too. There was a nearly 15% reduction in triglycerides and a healthy drop in non-HDL cholesterol.
So the bottom line is the 11.2% weight loss you get from oral Orforglipron is not just a number on a scale. It is clinically substantial.
Absolutely. It meets and exceeds that 10% threshold that we know triggers all these major cardiometabolic benefits. The data makes a very clear case that this small molecule pill delivers therapeutic value right up there with the injectable options.
Okay, so the efficacy is there, it's proven. But the story isn't complete without looking at safety. For a drug that people might take for years, tolerability is just as important as power.
And the safety profile was largely what we expected. It really mirrors what we see with all the other drugs that activate this GLP-1 pathway.
Meaning gastrointestinal issues.
Exactly. The most common side effects were things like nausea, diarrhea, vomiting, constipation, just general indigestion.
And it ties directly back to the mechanism, right? That slowing of the stomach.
It's a critical point for you to understand. It's the therapeutic action that causes the side effect. The food stays in the stomach longer, which makes you feel full, but it can also make you feel bloated or nauseous.
Were these side effects generally manageable for people?
For most, yes. They were typically described as mild to moderate, and they were most common during that initial period when the dose is being slowly increased.
As the body gets used to it.
Right. But they were significant enough that more people on the drug stopped taking it compared to placebo.
What were those discontinuation rates?
It ranged from about 5% to 10% in the active drug groups, mostly because of those GI issues. In the placebo group, it was only about 2.7%.
So while most people can handle it, there's a real minority, maybe 1 in 10, who will find it intolerable.
That seems to be the case. Now, moving on to the more serious safety questions. Pancreatitis is always a concern with this class.
And they did see a few cases, right? 5 cases of mild confirmed pancreatitis in ATTAIN-1, all in the drug groups.
Yes, though importantly, none were severe or had complications. It's a known, though rare, risk that needs to be monitored.
Okay, now we get to the big one. The issue that has torpedoed other drugs like this in the past. Liver safety.
This is a critical piece of the story. For you to understand why Orforglipron is such a big deal, you have to know that other small molecule oral GLP-1 drugs have failed at this exact point.
We're talking about drugs like Orforglipron and Danuglipron, which were stopped during development because of concerns about drug-induced liver injury.
Right. There was this huge cloud hanging over this whole class of drugs. So the question was, why would Orforglipron be any different?
And the answer seems to be that the researchers were acutely aware of this risk, and they designed the trials to watch for it like a hawk.
Extremely thorough and intensive monitoring. They were looking for any sign of drug-induced liver injury, specifically for big spikes in liver enzymes.
And what did that intense scrutiny find?
This is the crucial part. The analysis found no signal for drug-induced liver injury that could be blamed on Orforglipron.
So even though a few patients did have elevated liver enzymes.
Yes, 7 patients in the active groups. But for all 7 of those patients, the investigators were able to find other plausible causes for those elevations.
So they could rule out the drug as the cause. And that's the key difference.
It is the absolute key to its viability. If they hadn't been able to rule out the drug, it likely would have met the same fate as its predecessors. Its clean liver safety profile is maybe its biggest victory.
We should also just quickly mention the heart rate finding.
Yes, a slight increase in mean pulse rate, about 4 to 5 beats per minute higher in the Orforglipron groups. This is an expected finding with these drugs, and it's something doctors will monitor, but it's not seen as a major safety barrier.
Okay, so with the safety covered, let's talk limitations, the things the researchers themselves pointed out. How does Orforglipron stack up against the absolute best of the best on the market right now?
We have to be clear here. This pill is not quite as effective as the most powerful injectables.
Like tirzepatide.
Exactly. The highest doses of injectable tirzepatide have shown average weight loss of around 14.7% in diabetic patients. Orforglipron's 9.6% in that same population is, well, it's significantly lower.
That's a 5 percentage point gap.
Yeah.
So the central question becomes, is giving up that extra efficacy worth the convenience of a pill?
That's the trade-off. And it's complicated by the other major limitation, which is that these ATTAIN trials didn't do a direct head-to-head comparison against any of the injectables.
So we're always comparing across different trials with different patient groups, which is never a perfect comparison.
It's not. And one last quirky limitation you mentioned was the high dropout rate in the placebo group.
Right. Almost 30% of people on the placebo in the obesity trial just quit.
And that tells you something fascinating about the current environment. Patients are now so aware of how effective these treatments can be that if they think they're on a placebo,
they drop out to go get the real thing.
They do. And that's making these kinds of long-term placebo-controlled trials much, much harder to conduct.
So we've established the facts. Orforglipron is effective, it's safe from that critical liver standpoint, and it's obviously convenient. That brings us to the really profound part of this conversation, the implications.
This is all about that trade-off we just mentioned, and the consensus from experts seems to be leaning heavily in one direction.
And that is?
That for many, many patients, the ease, comfort, and accessibility of a pill will be a worthwhile trade-off for slightly less efficacy than the most potent injectables.
An 11% loss you'll actually take is better than a 15% loss from an injection you're too afraid of or can't afford to start.
Infinitely better. It shifts the goal from this pursuit of the absolute maximum number to pursuing the maximum beneficial loss that's actually achievable for the largest number of people.
And that idea of accessibility is tied directly to the economics. And this, for you, the listener, is probably the most exciting part of this entire story.
It is. The sources all highlight that Orforglipron, because it's a small molecule, is projected to be available in 2026, assuming it gets approved, at a significantly decreased cost compared to the current injectables.
One of the sources used a really powerful phrase. It said this could become the Metformin of obesity. Let's just sit with that for a second.
Metformin is the most prescribed, cheapest, most universally covered diabetes drug on the planet. If Orforglipron achieves that status for weight management, it changes primary care forever.
How so?
Right now, these powerful GLP-1 drugs are often prescribed by specialists, endocrinologists, cardiologists, partly because of the cost and complexity.
But if this becomes cheap and easy,
it democratizes treatment. Primary care physicians can start treating obesity and metabolic health aggressively and effectively right from the start without the current financial barriers.
Imagine if insurance companies cover it universally, making it a first-line therapy, just like metformin is for diabetes today.
It would open the door to treatment for the millions and millions of patients who currently can't even dream of affording the thousands of dollars a month for the injectables.
And that has to put pressure on the price of the injectables, too.
It creates enormous competition. If you, as a patient or a payer, can get 80% of the effect for maybe 10% of the cost, that is a very compelling choice. It could shift obesity treatment from a specialist, almost luxury intervention to just a routine part of preventative medicine.
And then there's the global impact. We can't forget that.
This is a monumental point. Injectable peptides need a cold chain. They need to be refrigerated from the factory to the pharmacy to your home.
Which is a huge challenge in many low and middle income countries.
In many parts of the world, it's impossible. Unreliable electricity, poor infrastructure. But a small molecule pill that's stable at room temperature.
It completely bypasses that entire logistical nightmare.
It means we could, for the first time, deliver a highly effective modern treatment for obesity and diabetes on a truly global scale, reaching billions of people who are currently left out. The public health implications are just staggering.
Let's just reinforce one final time why hitting that 10% weight loss target matters so much long term.
The evidence is just overwhelming. A 10% weight loss is consistently linked to huge reductions in heart attacks and strokes. The famous Look Ahead trial showed a 21% reduction in cardiovascular events for diabetic patients who lost 10% through lifestyle changes.
And we've seen it more recently with the injectable drugs as well.
Yes, the SELECT study. It showed that a 9.4% weight loss with injectable semaglutide led to a 20% reduction in major adverse cardiovascular events.
And the 11.2% loss that Orforglipron achieved falls right in that therapeutic sweet spot.
It does. It provides very strong evidence that patients taking this pill will likely see those same profound, long-term reductions in their risk of heart attack, stroke, and death. This isn't just about the number on the scale.
It's about reducing the entire burden of chronic disease across whole populations.
And the cost and convenience of this pill could finally be what makes that possible at scale.
So to summarize this whole deep dive, Orforglipron looks like a genuine breakthrough. It's an oral, non-peptide GLP-1 drug that has cleared the critical liver safety hurdle.
And it achieved clinically meaningful weight loss up to 11.2%, along with all the expected profound improvements in cardiometabolic health.
While it might not be quite as potent as the absolute strongest injectables, its potential for dramatically lower costs, easier distribution, and the simple convenience of a daily pill makes a very powerful case for its place in the world.
A case based on accessibility, on adherence, and on reaching the greatest number of people.
So here is the final provocative thought we want to leave you with, as this drug moves toward its potential arrival in 2026. Right now, there are more than 2.5 billion people worldwide affected by overweight and obesity.
An almost unimaginable number.
If this accessible, safe, and effective pill truly becomes the Metformin of obesity, how could that fundamentally restructure our entire approach to public health, moving weight management from a marginalized, expensive battle to a standard, successful part of primary care for everyone, everywhere?
That is the scale of the change we are watching unfold. The possibility of treating chronic disease at scale just became a lot more real.
Thank you for joining us for the deep dive. We hope this exploration has given you a complete and context-rich understanding of the data behind Orforglipron and its potential to truly reshape the future of medicine.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.